Hello, everybody, and welcome to the Hughes Clues CAD, or coronary artery disease, chronic stable angina, acute coronary syndrome, and acute myocardial infarction. This is part one of a two-part series. Lots of information, but before I begin with the information, I'm just going to do a reminder slide about the anatomy and physiology of the heart. If you look here, you can see that this is the aorta, and then right after, and this is the aortic valve here, right after the aortic valve, you have your two main coronary arteries, the right coronary artery and the left main coronary artery. And then, of course, each of those major branches or major arteries branch out into smaller. And in fact, the left main coronary artery will branch into other two additional major arteries, and that's the left anterior descending, or LAD, and the left circumflex. And again, as you can see, that as blood is ejected from the left ventricle, that newly oxygenated delivered blood will go straight into the coronary arteries, because for the heart to beat on and on, well, the heart muscle has to have oxygen, and oxygen is delivered in the oxygenated blood by the coronary arteries. So let's begin with coronary artery disease and chronic stable angina. And we have a patient, a 55-year-old female, who presents to the clinic with a complaint of dyspnea. Identify the major risk factors that may accelerate the development of atherosclerosis and place her at risk for cardiac issues, and indicate whether the risk factor is modifiable or non-modifiable. And truly, if you have done other courses, and I know you have, J1 and J2, I don't want to belabor this because you know it, but I just want to identify or make sure that you're aware that all of us have atherosclerosis, or the development of plaque in our arteries, but there are certain things that really do accelerate plaque formation in the coronary arteries. And that, of course, is going to be a high triglyceride or a high LDL, smoking and diabetes and hypertension. These things really, really aggravate and accelerate the development of plaque, and that's what this picture is down below. This is the development of plaque in the coronary arteries that, just like your pipes in the sink, it essentially clogs up that artery and makes it difficult for blood to go through. Now, there are other modifiable risk factors that include inactivity and diet, obesity, and so on and so on. And you can, again, pause the recording and read about that. Again, I don't want to belabor this. I think it's important for you to identify what's modifiable versus non-modifiable, because you know these things, but just make sure you look for it in an exam question, because the non-modifiable things are things that patients really can't do anything about, are their age, because you either age or you don't, and then of course their race, gender, and family history. These are things that are far beyond our individual control as of right now. So when we go back to our subject, a 55-year-old female presents to the clinic with a complaint of dyspnea. And she's got a strong family history of cardiac problems, and type 2 diabetes has been identified. She smokes 3 packs a day. Her BMI, or body mass index, is greater than 30. She rarely exercises, and she drinks 3 beers a day. So which risk factors would indicate this patient is at risk for CAD, and then which health screening and diagnostic tests might be prescribed as a result of her visit in the clinic? So let's look at this slide. You can see that this individual, as we discussed, she's got a strong family history of type 2 diabetes and cardiac history, and then on top of it, her lifestyle choices are just make her the poster child for coronary artery disease. And when we talk about coronary artery disease, which is this big red circle, you can see that any individual who's at risk for coronary artery disease is truly at risk for cerebral vascular disease and peripheral vascular disease. You can see that right here, if I drew this correctly, this one right here should actually be all red, and this is where the link is strong. If you can actually have all 3 diseases, but you can anticipate in many patients that if they have one, they likely have diseased arteries in other places of the body. So which health screening and diagnostic testing might be prescribed? So one of the first things that's going to be done is a 12-lead EKG. And maybe you've heard about this, but if not, let me explain it. So 12-lead EKG just means that when we look at the heart's electrical activity, we can look at it from 12 different views or 12 different angles. And what will happen is they'll place electrodes in different places, and then the electrical activity is taken from all these 12 different angles or 12 different views of the heart. And this is very important because it can identify a lot of specific problems like conduction problems, dysrhythmias, how big the heart is, whether it's too big or whether it's not, whether the patient's having a heart attack or if they have a pacemaker, and so on and so on. So a 12-lead EKG is really the diagnostic thing that physicians will use. You as a nurse are not going to be responsible for knowing how to read a 12-lead EKG in this course. Which other health screening and diagnostic testings might be prescribed? Well, we know that she has a family history of diabetes, so we do need to check for her fasting glucose levels. We also we see that she's obese, so therefore we need to do a lipid panel, which would include a triglyceride. It would include the measurement of LDL, which are the lousy cholesterol, HDL, or the healthy cholesterol. And I've given you some numbers as far as averages. I don't believe that Dr. Reed ever asked you what numbers are, but you're all about health education, teaching the patients, and so therefore you kind of need to know these to just get a ballpark. And of course, we need to check her blood pressure because hypertension places her at risk for coronary artery disease. Height and weight is going to be utilized to calculate the body mass index, and a body mass index of 30 indicates obesity. I think 25, anything above 25 is overweight, anything above 30 is obese. And then because we talked about the fact that coronary artery disease is often accompanied by arterial disease in other spaces such as in the brain or in the legs, you would want to assess her peripheral pulses because if she doesn't have any, then there is a concern for peripheral vascular disease. Some other tests that could be ordered by a physician are an echocardiogram, short for echo, a transesophageal echo, a little bit different, a little bit more invasive. Again, pause the recording and look. It's not often that Dr. Reed asks about these tests, but every once in a while you are asked. And then notice that there's exercise test and nuclear testing. Now, an exercise stress test can be done on some individuals, but let's say the individual hasn't walked any further than from the recliner to the refrigerator. Sometimes the stress test is not going to be very reliable, so they do what's called nuclear testing, where they inject certain medications and then they can look at it without making somebody walk on a treadmill. Again, it's not important for you to identify, well, which ones need to be prescribed, because this is a physician decision, and you just want to look at the heart muscle as far as is there enough pipeline, or are the coronary arteries open enough to deliver blood while the patient is doing more strenuous exercise. And indeed, with this patient, our poster child for coronary artery disease, during the exercise stress test, she experienced dyspnea and chest discomfort. And the EKG showed ischemic changes, which we'll talk about what that means in just a minute. So they stopped the stress test because it's clearly positive. So what might be the cause of these symptoms? Well, the symptoms could related to what's known as myocardial ischemia. And as we go through this presentation, I'm going to talk to you about what I call the 3 I's, and that's ischemia, injury, and infarction. So we talk first about ischemia. What does ischemia mean? Well, ischemia means that the coronary artery is simply not able to deliver enough oxygen to what the muscle needs at the time. So it's less oxygen being delivered than what is needed. So if you look down here at our there we go. At our picture perfect artery without any disease, you can see that blood is able to flow really well through this pipe. And that's what you think about the coronary arteries, as a pipe. Whereas down here in the picture below it with this plaque or atherosclerosis formation, you can see that the ability to deliver oxygen and blood, and therefore oxygen, is going to be completely or definitely decreased because there isn't enough space for the blood to flow. And this is just another angle at it that you're looking. If this should be, this big green circle should be the lumen or the space that blood is flowing, and when there is atherosclerosis, it greatly narrows that. So you should always think about ischemia as an O2 demand and supply problem, whereas the demand, meaning the need of oxygen of the myocardium or the heart muscle, is far greater than that artery is able to supply. And that's really, really, really the crux of coronary artery disease, a problem with O2 demand and supply. Again, be sure and read all of these things. We do associate crushing chest pain, diaphoresis, and nausea with myocardial ischemia. I do want to point out that women do have atypical symptoms. They will complain of fatigue and GI symptoms and shortness of breath more so than men, who will complain more of that crushing type injury. So the patient failed the exercise stress test, and therefore the physician needs to get a specific or a very detailed look at the coronary arteries and how badly are they blocked. Now, there are, again, several different tests that do that, but really the gold standard is the coronary angiogram, otherwise known as cardiac catheterization. And so you can see from this diagram here that a hole is poked in the femoral artery. It can be in other arteries, but we're just going to use one, and that's the femoral artery. And then you're basically going against the flow of blood, so you're going upstream around the aortic arch, and then that catheter injects dyes directly into the coronary arteries, and then we can get a very good 3D picture of what the coronary arteries look like as far as how open or closed they are. And then there are some other tests that can be obtained while the patient is having this cardiac catheterization. As I mentioned, contrast medium or dye is used, and so individuals who are allergic to iodine or shellfish can have problems, as well as remember or recall or know that the contrast has to be cleared by the kidney. So prior to the exam, you would definitely want to assess the kidney function. Because these patients are lying flat on their back on an ironing board during the procedure, then they have to be NPO, and also because they're given conscious sedation, and we don't want a patient who cannot manage their airway to upchuck while they're lying on a ironing board, and so that causes the risk for aspiration. So NPO. Pre-op check, again, because we're poking a hole, and the hole is about the size of a very, very, very small neonate from the artery and the catheter, but you still are checking or you are poking a hole in the femoral artery. So we need to assess the peripheral pulses before the procedure, and then after the procedure, then they'll also be assessed. So these are the worst case scenario pictures. You can see here the femoral artery is somewhere in this range, and I know anatomy looks odd here because this is a huge collection of blood that's underneath the skin, which is known as a hematoma. Here it is here. It's not as discolored and dramatic, but no matter, the complication, or the most common complication when you poke a hole in one of the largest arteries in the body, is of course bleeding. Sensation has to be assessed after the procedure because, again, we talked about the fact that if plaque is in a coronary artery, it can be in the femoral artery, and as the physician puts the catheter and device in, it can shear off that plaque, and it can go downstream and occlude all of the circulatory pathway downstream. And that's what this leg looks like. It's pretty dusky because circulation is poor. So these are the things that need to be assessed post-cardiac catheterization. So when we go back to our patient, the physician's done a cardiac catheterization. There is definitely arteries that have disease or occlusions in them, not bad enough to be fixed, and so therefore the patient is diagnosed with chronic stable angina. So what does that mean? What does the pattern of the illness state look like, and what are the critical teaching points that you, the nurse, would need to do. So chronic stable angina means that the individual will have intermittent chest pain, and that intermittent chest pain will occur at the same time or whenever the same activity is done with the same pattern, onset, duration, and intensity. In other words, every time the patient gets up to go get the beer out of the fridge, then she's going to experience this pain, and it's going to have the same pattern. And the pain will usually subside when she sits back down, or if she takes some medication to alleviate the pain. So again, chronic stable angina just means same pattern, very consistent, always occurs with the same activity. And again, the precipitating factors are going to be physical exertion. That's one of them, because again, you're talking about more demand. The myocardium needs more oxygen whenever there's more activity, and that coronary artery during that higher demand time is not able to supply it. Now, temperature extremes, emotional upset, heavy meals, and smoking can also cause increased demand because of what happens during these activities. So the teaching point is that you've got to let the individual know that, okay, you're supposed to have chronic stable angina every time you get up. Maybe before you get up, you should take a nitroglycerin or some kind of medication. But if, for instance, you get pain at rest, then you need to seek medical attention, or if the pain changes or the pattern becomes worse. And then, of course, this is not just because it's been diagnosed doesn't mean that, she can live forever with this pattern. Things will get worse unless she changes her habits. And then, of course, if there's medication prescribed, teaching would be done about that medication and the consistency of taking that medication. And again, if she doesn't make changes and do what she's supposed to, then unstable angina could begin, or an acute MI. So let's talk about the treatment goals of a patient who has chronic stable angina. And we've already talked about the fact that it's a supply and demand issue. So again, the goals are going to be, well, make sure that the demand is down so that the myocardium doesn't need a lot of oxygen in one hit, and then also trying to improve the supply. So how do we accomplish those goals? And of course, I've already alluded to the fact that the individual may need to either take nitroglycerin once the pain begins, or to prevent the pain from occurring in the first place, maybe take nitroglycerin. So what is the big deal about nitroglycerin? How does it help? Well, nitroglycerin dilates the coronary arteries. Nitroglycerin dilates the coronary arteries, and so that will increase the ability to supply more O2. And there are other drugs that are needed. And of course, nitroglycerin, you are familiar with it. It can be sublingual in a spray or a tablet, and then there's patches. Different ways to deliver it. So let's talk about some other things, because we did say, well, you want to increase the supply, and we can do that by vasodilating the coronary artery. But when we look at this is really the list, or the acronym for the treatment of coronary artery disease, and it's as easy as A, B, C, D. So when we talk about A, we would use an ACE inhibitor. This would be an antihypertensive. And again, be sure and pause the recording and look at all of the details. I think most of you are familiar with ACE inhibitors. Those are the drugs that end in ill. And again, I don't want to just belabor the obvious and just read something that you can very easily read, but ACE inhibitors, antihypertensive, remember that hypertension is a part of the problem that will accelerate plaque formation, and of course it also increases the workload of the heart. So we don't want to increase demand. We need to decrease demand by getting that blood pressure under control. Now let's talk about a beta blocker. Many of you, or most of you, know about a beta blocker. But when I ask most students, well, how does it work? Everybody says, well, it lowers the blood pressure. Well, that's kind of true. It really is a little bit more than that. And this is the part you need to do. How does a beta blocker decrease myocardial oxygen demand? Well, we talk about the beta adrenergic, and that is the beta, epinephrine that will cause the beta adrenergic receptors on the heart muscle to increase the force of myocardial contraction and increase the heart rate. Therefore, a beta blocker will decrease the heart rate and decrease the force of myocardial contraction. And that's how the blood pressure goes down, because the cardiac output goes down. So we know that beta blockers end in OL, and there's different kinds of beta blockers, beta 1 versus beta 2, not necessary that you know about. I think the biggest thing that you need to know is if a beta blocker is taken. And let's say now you make this patient, because every single elevator in a building is not working, and so the patient has to go up one flight of stairs, and I would have an increase in heart rate. And with a beta blocker, then if they were to climb a flight of stairs, that increase in heart rate won't go up, and therefore the oxygen demand won't necessarily go up for the heart. So that's how it helps. The downside of a beta blocker, especially when it's first initiated, is the patient will complain of profound fatigue, which is why sometimes they stop taking it. Again, the heart rate, the beta blocker should be stopped so many hours before a stress test, because in a stress test we want the heart rate to go up, and this will inhibit it. So there's some reasons or adverse response to a beta blocker. Heart rate must be checked, blood pressure must be checked before administration. So let's talk about the C, and that's the calcium channel blocker. These are drugs that end in INE or PINE, the PINs, and calcium channel blockers cause arterial vasodilation, and sometimes they prevent arterial vasospasm, because that's what causes chest pain in some individuals with a special group of variant angina. And then there's dietary drugs. There's lipid-lowering drugs such as the statins. And with a statin, it's very important that the individual have their liver enzyme checked when they initiate the statin. And then because the statin can cause a rare condition of muscle breakdown known as rhabdomyolysis, if any individual has muscle pain with a statin, then they need to contact their physician and stop taking the statin. There's other drugs that help with statins as well as red wine. This concludes our session on coronary artery disease and chronic stable angina. I hope this has been helpful.